I'm really excited to introduce Dr. Maida Chen. Her talk is on updates on infant sleep. She received her medical degree from Northwestern University. She trained at Rush Children's Hospital for general pediatrics and completed her pediatric pulmonary fellowship at Children's Hospital in Los Angeles. She was part of an inaugural class of sleep medicine board certified physicians, as sleep medicine was not a formal subspecialty in 2007. She joined faculty at the University of Washington and Seattle Children's Hospital in 2005 and is currently a professor of pediatrics and director of sleep medicine, as well as adjunct professor in the School of Dentistry. So please welcome Dr. Maida Chen. And I'm going to stop sharing so she has a chance to share her screen and get set up, and it may take a moment.
All right. Can people hear me?
And
All right. And
yes.
We can see the right slides. Thank you so much for that introduction. I was saying earlier, it's always a little mortifying to hear about yourself in that way. Thank you, everybody, for joining us today. And thank you very much for the land acknowledgement as well, Monica. So without further ado, I am going to be talking today on infant sleep, which is something that obviously all of us who are here had to go through at one point in time, and all of our parents had to go through it with us. But it is something that is oftentimes not addressed at a training level for people who work with infants a lot. Today's objectives, really, what I'm hoping to have imparted on you guys as audience members are just some of the following. And again, this is high level. Any one of these topics alone could take, days worth of lectures. But for today and in this next hour, we're going to review a little bit about the basics of sleep physiology, talk about the approach to and the assessment of infant sleep difficulties, talk about some of the updated evidence on safe sleep environments, which we know is so very critical in infant mortality in this country, and then impacts on infant sleep on health and development. I'd like to also provide the disclaimer that this is not a technical focused presentation, in the sense that I've really tried to keep things clinically relevant, a little bit more real world as opposed to experiential models out there. So a lot of the studies that I will be presenting count as an evidence base, but are oftentimes parent reports. And to me, that's incredibly important because they are the eyes, ears, and voices of our infants, at least in those early stages. So let's start with a review of the basics of sleep physiology. So if there is one thing that people oftentimes think about sleep, is they oftentimes think of sleep as a state of quiescence, where the brain is sort of shut off. But really what I would like to reiterate today is that sleep is actually an incredibly active, dynamic state that requires activation of several neuronal circuits, that has to have synchronized activation and deactivation of those circuits. And any disruptors to those circuits, whether it's teratogenic exposures in utero like alcohol, whether it's altered neurotransmitters that can occur with mood disorders, whether it is environmental influences like stress or pollutants or certain medications, any one of those can alter sleep and alertness. And how each unique person, whether they're an infant or a grown-up, handles those disruptions is very individualized, and it's impossible to predict sort of a one-for-all model. So how does sleep happen? Really, in the most simplistic form, there's several series of sleep switches that need to turn on and a bunch of awake switches that need to turn off. But both of those need to synchronize and happen in order for sleep to be initiated and maintained. So it's not just a one-way switch of sort of on-off type of things. It's a bilateral, bi-directional set of activation and deactivations. There are two big drivers in sleep, which is really an active dynamic state. The first thing is what we call process S, or sleep homeostasis. This is a very basic concept, which is just that the longer you are awake, the more you need to sleep. So if you are awake for 18 hours, your sleep pressure is quite high. And if given the opportunity, you will likely fall asleep. Versus if you have just woken up and you've only been up for an hour, it is less likely that you will be able to fall asleep quickly. So that's a pretty straightforward thing, sleep pressure. The next one is something called circadian process or process C. This is something that is our 24-hour rhythm. It's where we get essentially light signals through our endogenous pacemakers. And this is the thing that says at 8, 9, 10 o'clock in the morning, we're relatively awake compared to 2 or 3 o'clock in the early morning hours. And that's because our bodies are used to that. Like same things where we get hungry around lunchtime and where we get hungry around dinner time, those sorts of things. So that is a circadian process. Those are body clock rhythms that occur. And every cell in the body has a circadian process. So to break it down a little bit more, sleep pressure, the rate of rise of sleep pressure changes across the lifespan. So you have infants who honestly, for those of us who work with infants, especially in that newborn state, they can't stay awake much longer than an hour or two at the beginning. And that rate of rise then slowly decreases such that toddlers and preschoolers can maybe stay awake for 6 to 8 hours. Elementary kids can stay awake for a full 12 hours. And during this process, they eliminate that afternoon nap. Adults can stay awake a good 16, 18 hours. This actually gets a little bit shorter again as we age into our elderly years. And teenagers, which is a problem in and of itself, teenagers can stay awake for a very long time. And so their rate of rise of sleep pressure is quite slow, which partially explains why they can always stay up later and later and later. So that's sleep pressure across the lifetime. What about the emergence of circadian rhythm? This is what looks like a really whole lot of squiggles, but each one of these horizontal lines is essentially a day, a 24-hour circuit in a newborn's life. And this was done by Nathaniel Kleitman, who is one of the grandfathers of sleep medicine. This is midnight on this side and midnight on another side, so essentially 24 hours. And all the black lines are when his newborn infant slept. And so if you take this apart, this is in the first year of that child's life. And here in the first, it's the first 6 months of this child's life. And in the top half, this is the first 3 months. So you can see in terms of where the black lines are, they don't line up with one another day after day. They're kind of all over the place. And this really illustrates how there's no reliable circadian rhythm in those first 3 months of life. What you do see is later on, you see progressively longer bouts of these black stretches, which are sleep. Doesn't mean that they're necessarily at the same time every day, but there is the emergence of these longer patterns of sleep, longer stretches of sleep. But then if you look at the second 3 months, so from 3 to 6 months, you can see that right around that 3 or 4 month time point, this child started developing a clear circadian rhythm where the blacks lined up with one another and where the alert periods lined up with one another. You can see that this child continued through the first 6 months of life, having intermittent naps throughout this large chunk of wakefulness, which really, ended up being at about from 8 a.m. to about 8 p.m. And you can see that the bulk of 24-hour sleep started occurring between essentially 8 p.m. and 8 a.m. by the time that this child was really 3-4 months of age. So that's when we start to see the emergence of that circadian rhythm. And part of sort of anticipatory guidance and education is telling parents that this is going to happen around that time point and to be prepared for it. Many of us will say, don't worry about the first couple months of life in terms of trying to create a rhythm or pattern, but you don't know when your child is going to be developing this circadian rhythm. And unless parents are prepared with the habits that they want and the sleep goals that they have for their child, that circadian emergence may sneak up on them without them realizing it. So what about sleep stages across the lifespan? So infants spend the majority of their sleep time in what we call REM sleep or active sleep. So REM sleep in older children and adults is about a quarter of the sleep then. And you can see proportionately across the lifespan that infants who are on this end of the graph versus those adults who are on this end of the graph, that REM sleep is a larger proportion of overall sleep. And it wanes quickly over the first year of life. The other thing that we've noticed is that infants have a very short REM, non-REM cycle, where they will, the blues are REM sleep. And you can see across the night that this child will have REM cycles every 60 to 90 minutes about, versus in the adult, it is every 3 to 4 hours, 2 to 3 to 3 to 4 hours, depending on what part of the night. Part of this is we believe that REM is really involved with learning and memory consolidation. And if you think about it, there's really no other time that you learn more than your first year of life. It's a little sad to say that, those of us in our adult years don't have as much REM sleep. And does that suggest we're not as capable of as much memory consolidation and learning? That may be by design, because really many of our physiologic functions are in place by that time, versus in infants are rapidly changing with a rapid period of growth that first year of life. So that is something that is quite different. And if you just observe a baby sleep, you can see these differences in REM and non-REM sleep. In REM sleep, they will oftentimes have very frequent eyelid fluttering, and those are the rapid eye movements, or the RE in REM sleep. They will often have little twitches of their hands and feet. Their breathing becomes very irregular. This is also when they can bust out that smile in the middle of their dreams. Who knows what they're dreaming about, but this is oftentimes what parents will say, that they first have a smile, which is not particularly a social smile, but nevertheless still incredibly adorable and really important for a lot of parents to see in those early first weeks. So in terms of the summary points of those basics of sleep physiology, so sleep, remember, is an active state. It's neurologically complex. It's driven by two primary processes: sleep pressure and circadian pressure. Our circadian rhythm starts to develop around 3 to 6 months of age, and infant sleep is characterized by a much higher percentage of REM sleep and very fast REM cycles compared to older children and adults. So moving on to the approach and assessment of infant sleep difficulties. Let me pause here for a second and say that I see that there's a lot of activity in the chat. I am not actively monitoring the chat because I am not capable of doing that many things at once. So I am happy to go through the chat questions later, and we'll try to cluster questions towards the end. So I apologize for that in advance. I also see that there's nearly 400 people in this lecture, so thank you again for coming. Okay, approach to an assessment of infant sleep difficulties. So the current approach to identifying a sleep problem in infants is basically parental report. A parent states, my child has a sleep problem. Pretty much by definition, that baby has a sleep problem. It may or may not be one that we would be able to objectively quantify on any sort of objective testing. But if the perception is there, there is at least, at the very least, some incongruence between what the parent believes and maybe what is actually happening. So problem exists. And the reality is we know that caregiver-reported sleep problems in childhood are incredibly common, and particularly insomnia, and they tend to be persistent through childhood. So we can see here in this large study that was caregiver reported, I think this was close to 6,000 children, done by Ariel Williamson and colleagues, that the prevalence of sleep problems in that first year of life was high, especially with wakings overnight that occurred upwards of 40% of children in that first year, and still high levels of things like sleep problems, trouble getting to sleep, not happy to sleep alone within that first year. While there is a decrease naturally with time in terms of wakings overnight, you can see that anywhere from 10 to 20% of children still report some sleep problem persisting all the way until their teenage years. So the first thing I like to remind both providers and parents is that this is a common issue, and it's more common than a lot of parents are aware of believing. And it's also something that a lot of parents carry a lot of shame around, in terms of if they don't have a child who is sleeping the way that society wants them to be sleeping by a certain age, they find it to be a parental failure. It really does bring up sort of the question, though, how does one define good sleep? There are lots of things we can throw out there, things like quantity of sleep, quality of sleep, the timing of it, how satisfied you are with it. Is the kid actually functionally alert during the day, or are they napping too much? Is it efficient? Meaning, when you lay the baby down, do they go to sleep pretty quickly and stay asleep while they are in that crib or wherever they're sleeping? Are their behaviors the way you want them to be? There is so much for us to learn as a discipline about good sleep in infants. Particularly, and I really feel the need to call this out from a culturally diverse and equity lens. Many of the studies that have been done centered around a certain demographic, which has been white, largely middle class, moderate educated families that have not taken into account a lot of the global practices we have seen around the world that are less common or less accepted anyway in this country. Who gets to define good sleep? Definitely the parent, a provider too, certainly, and somebody who may be looking at the situation and recognizing that there are sequelae to this child's sleep that are not optimal for health and development. I think the child gets to define good sleep in the sense of the child is happy, something is going well. But I'll tell you who should not be defining good sleep is social media. And that is unfortunately something that has become much too relevant these days in terms of the need for perfection and the need for curating this life that matches what social media shows. When we talk about how to approach families, caregivers about infant sleep histories, the first thing to know is that parents and really any caregiver may not be the historian we think they should be in terms of accuracy, knowledgeability. And what we know also, and this is a huge point, is that sleep deprived parents have really poor judgment around their own child's sleep and health. So you have this parent here who is maybe camping out on the couch a little too much, has no idea what's up or down, and may report that this child is a terrible sleeper. Whereas objectively, this child may be getting as much sleep as this child, or this child, or this child. And you can see various definitions of what could be good sleep, or what may be dangerous sleep. What does sleepiness look like, or what does poor sleep look like in a child? When we think of this in adults, we think of things like overt sleepiness. An adult or even an older teenager who is not well slept, either poor quality or insufficient duration, is just overtly sleepy the next day. They have pissy moods. They may be self-medicating with caffeine. But those things are so much harder to ascertain in babies. So in babies, what are the things that we can look for? And so really this is a bit more limited to babies who are greater than 3 months of age, but they usually present with fussiness more than anything else, and they'll have alterations of their eating and drinking habits. We have to remember that most infants, not all, but most infants are neurologically capable of learning independent sleep, but it is a skill just like everything else they have to learn. And so you can definitely have an infant that is too tired to go to sleep. Remember that some of those first slides where I showed the sleep switch on and the wake switch off. If you are so tired that you don't have the organizational function to do those, or let's say you have a major teratogenic exposure in utero that prevents those circuits from forming, you can be absolutely too tired to go to sleep, and you can be too tired to stay asleep. Seems like the irony of all ironies. Some of those missed window signs can include things like yawning. I was trained in a sleep environment where yawning was a sign that you were too late. You missed the window for that baby falling asleep. Things like falling asleep every time that they're in a car seat, waking up shortly into a nap, or waking up shortly into overnight sleep, especially after 3 months of age. Or they wake up crying instead of waking up happy. And these are pictures that we all know where the baby, parents talk about it all the time, and we see it in those of us who take care of infants, that they've missed that window, that there is a window, the witching hours, if you want to call it that, where you have to get that baby down, because otherwise they are so wound up, it is difficult for them to organize a response to fall asleep and stay asleep. How to approach it. And so in pediatrics, those who have had pediatric clinical care training oftentimes are taught this acronym, or the BEARS, where we go through a sleep history that includes asking about bedtime problems, excessive daytime sleepiness, awakenings after sleep onset, sleep routines, and snoring. And in sleep clinic, I just easily start at dinner time, and I have the luxury of then going through a complete 24-hour day of sleep and wake habits, behaviors, and concerns. In infants, I think there needs to be particular focus, though, on things like sleeping arrangements, who's sleeping in what bed, in what room, and how often. And I get really detailed sometimes about those questions. What is the sleep routine and schedule? If a family can't tell me any of that, that's telling in and of itself. How are nighttime awakenings handled? Are they handled with consistency? Are they handled differently every single time? Are there other medical problems involved? How are parents sleeping? And what do the parents truly want? A lot of parents secretly, or maybe not so secretly, love co-sleeping with their children, even though they've been told over and over again it's something that they're not, quote unquote, supposed to do. I utilize sleep diaries quite a bit. There are a million digital applications of sleep diaries out there, and I'm not here to endorse one over the other. I'm actually here to endorse good old-fashioned pen and paper, or pencil and paper. I love the concept of not having this digitized to get people off phones, but also it just forces parents to observe and record prospectively. If you ask parents to do this retrospectively, like what happened 2 days ago, honestly, especially in these first several months of life, they have no idea what happened. Even today, I think many of us in the audience wouldn't be able to recall what we had for dinner, at least very quickly last night, or even breakfast this morning if you had it. And so this is something that really needs to be recorded prospectively and in the moment. Sleep diaries can be oftentimes diagnostic for circadian rhythms and problems, insomnia, insufficient or sufficient sleep. And it's helpful for evaluating treatment success. And it's low tech, right? Just about anybody can do this with a fairly elementary level of literacy. Questionnaires. Again, questionnaires are inherently dependent on observations, and it tends to essentially standardize that sleep history. Most common one used in babies is the Brief Infant Sleep Questionnaire. There's a revised, shortened version of it. Goes through a lot of the questions that we talked about. It was developed by Avi Sadeh back in the early 2000s, and it's been since validated in multiple languages and across multiple populations. This is not something that has been standardized, though, to clinical care. It's still used largely in research settings. Actigraphy. So actigraphy is something that is a device that monitors motion, an accelerometer, essentially. It assumes that a lack of motion means that the kid is quiet and, not moving, physically quiet, and certain algorithmic determinations then say that that is sleep. This is largely done in older children and adults. It is typically done on a non-dominant wrist. Almost a lot of adults have these now, and they are known as phones of Apple Watches and Fitbits and things like that. It is very similar technology. Medical grade ones tend to have longer batteries and slightly more sensitivity, but it's really the same concept. One can imagine that there are some logistical hurdles in doing this on infants, but it has been done, and I do think there is a role and place for it, and future benefit in the research world, and hopefully eventually the clinical world. You can see that in an older child or adult, it's oftentimes, like I said, on their wrist. We can put it around the foot, leg, sometimes even the torso of an infant. This one has both on. And what we get is this pattern of the black is activity. There's a light meter in theirs. And so the yellow, you can see what the light exposure is. And then these periods of no black, low light levels that we are calling sleep, or that the computer algorithm then calls sleep. Sleep study. A sleep study looks objectively at brain function, awakening, sleep quality and stages, excuse me, body movements, and breathing during sleep. What we actually monitor are all those things. And the question that everybody asks me is there any way a baby can actually tolerate that? And the reality is yes, we have very few truncated or aborted studies due to patient intolerance. We are almost always able to get the information we need in infants. It's not perfect, it's not easy, and I really, really, really feel very strongly that it is only as good as your technicians. And so would highly encourage infants who, where there is concern for more significant sleep issues, that they have sleep studies done at a pediatric specific center. center. Most sleep laboratories will not touch children less than 2 years of age for good reason. It's technically way more challenging, but we can do it. And while these are all relatively calm, happy infants of varying age groups, this is the standard in terms of what babies will look like when they're set up for it. And the reality is we can get good data after infants like this who are relatively unhappy with the setup process. We can get good data after they fall asleep in the hands of a good technician. So, summary of assessment of infant sleep difficulties, largely based on parental perception and beliefs, which I think are critical and foundational to our work with these families. That's oftentimes been poo-pooed in the past, and I really think that it needs to be the central component of our approaches. The definitions of good sleep are oftentimes biased in our literature to white middle-class populations that differ significantly from global infant sleep practices. We have a lot to learn from the rest of the world. Parents can be very biased reporters, and they may not be as accurate as we would like to believe they are. And the more sleep deprived they are, the less reliable of reporters they are. Infants manifest sleepiness very differently than older children and adults. And so it's something to keep in mind where, a lot of families will be like, oh, look how cute that is. They're yawning. And some people would say they've missed that window by the time they're yawning. Assessments then can include caregiver reported history, sleep diaries, questionnaires, actigraphy, and polysomnography. So moving on, let's talk about updated evidence on safe sleep environments. So SIDS is now I shouldn't say it was renamed, but is now part of a bigger syndrome called sudden unexplained infant death. I don't know what the appropriate pronunciation of that is. But of sudden infant deaths that are unexplained otherwise, 40% of them are due to SIDS in the prior definition of SIDS, 32% of are unknown causes, and a third are due to accidental suffocation and strangulation in bed. This is a lot of babies. This is 3,400 deaths per year in the US as reported in 2020. And what we know is that behind essentially birth defects and prematurity, SIDS is the third leading cause of infant death in this country in that first first several months of life. So this is a historic figure, one that still is relevant though, which looks at this triple risk model for SIDS, which includes essentially having a vulnerable infant that's got probably the right genetics, some degree of prenatal exposures, predisposed with prematurity and being male, an exogenous stressor. And many of these are things that we try really hard to control for. There's things like their sleep environment. And then in that right critical developmental period, which listed here is between 0 and 12 months, but really what we know peaks at around 2 to 4 months. The American Academy of Pediatrics came out with updated sleep environment recommendations. This is an update to their 2016 recommendations. This table is entirely too difficult to read. So I've taken the next 2 slides to just summarize some of the recommendations from 2016 to 2022. So sleep surface in 2016, it was firm surface. In 2022, the new ones, still a firm surface, and this time very explicitly saying a flat surface, so without a wedge. This is a big deal as many of us, particularly for medically complex kids, were empirically treating sleep difficulties with wedges anywhere from 25 to 40 degrees. And wedges were recently not approved by the CPSC, which is a safety commission. There is one wedge that is FDA sort of sanctioned at this point in time. That is a 25-degree one that's attached with the sling. It specifically calls out that cradle boards used in certain Native American cultures are okay. It goes on then in terms of breastfeeding recommendations, which in 2016 suggested that it be exclusive for 6 months. Here they are a little bit wider in saying just human milk exclusive for 6 months or longer, more important in preemies, but really call out being inclusive and sensitive and discussing breastfeeding as opposed to having the child given breast milk and then just fed is best in general. Location. This is a hard one for me personally. Room sharing, but not bed sharing for a year, was the 2016 recommendation that has been shortened to 6 months, although everybody, like the recommendation still is up to a year, but definitely try to focus on at least the first 6 months, and definitely still not recommending bed sharing. Bed sharing was that much worse if the bed sharer adult had impaired alertness, was a smoker, or it was a soft surface. A little less offensive if the baby was less than 4 months of age or not a parent that was in bed with them, and least offensive if it were a preterm baby or soft bedding accessories if they were to bed share. Adult beds were still viewed to be better and safer environments than a sofa or an armchair. Co-bedding for twins was suggested against. Bedding, really, wearable blankets were recommended in 2016. In 2022, came out to say no weighted blankets and that layers were better than blankets to avoid covering their heads. They call out that hats are not okay, except for in the first few hours of life or in the NICU. I know a lot of grandmothers who would disagree with that. Home monitors. In 2016, they said that there was no data available. In 2022, they said that there was no contraindication to using them as a wellness device, but that there was no data to support use as death prevention. And essentially, they said, don't do it to get out of these safe sleep recommendations. I think home monitoring is important as things like the Owlet and the Snoo bed. Again, I'm not endorsing them, just mentioning them as products that are available and commercially out there, became very popular in the last several years and recently have both been rescinded in terms of being quote unquote safety devices. Swaddling, don't do it after they are rolling. Healthcare professionals and childcare providers and media, we should all be practicing good SIDS reduction habits, and especially hospitals, which we don't. I'll show you some pictures in a bit. And then they went on to talk about education and research, which were additions to the 2022 guidelines as opposed to the 2016. But ultimately still place them on their backs without anything else in the bed, avoiding bumpers, loose blankets, any sort of stuffed animals, really as firm and as bare of a surface as possible. Some pictorials that came out with it, really showing in terms of the infant in back to sleep positions, a lot of people used to think that this placed them at higher risk for aspiration if they were to vomit or spit up during sleep. And what this picture is showing that because of gravity, if the child does vomit, it is less likely to go into their lungs because that is on top of what their esophagus is, and likely they would just swallow it back down, as opposed to in the prone position where the trachea was actually the one that was higher up and the esophagus was actually compressed. So higher likelihood of actually aspirating. Showing some pictures of accidental strangulation in terms of suffocating and soft bedding, overlaying by specifically overtired parents or being entrapped between the bed and the wall. This was something that was touted as sort of the ideal environment, having the infant in the same room in a room sharing sleep surface that was separate from the parent bed. There are obviously a lot of things that this picture may not be necessarily inclusive of. First and foremost, being families who can afford a separate sleep surface or have the room for a separate sleep surface. Just to demonstrate that the hospital has a long way to go. And so for especially graduates of the NICU, for families who have spent a lot of time beginning of life in the NICU, hospitals sometimes are the worst place that we see infant sleep, good sleep practices. And so if you look at both of these infants, they are both up on wedges, which have now been really strongly discouraged. This kid has his face smushed right into a blanket with a wedge type device there. This one has a blanket covering their face, has a hat on, lots of loose blankets in the bed. So lots to improve on. And, you know, when families, especially families of children who had medical challenges early in life, they learn to model these practices at home as well. So we know, though, that the AAP guidelines are not always followed. In fact, not frequently followed, and probably at degrees much less than reported because people don't want to report it. I would just remind everybody that the absence of evidence is not evidence as absence or inferiority. The things that I find lacking from these guidelines are the impact of room sharing on working parents, on single caregivers, the psychological, emotional stress of impact of not following cultural practices. So for a lot of families that maybe whose moms didn't necessarily grow up here or were raised differently, they have different viewpoints. And it's oftentimes a very big conflict in terms of what they thought was supposed to happen versus what they are being told. Feasibility of creating the recommended infant sleep environments in a wide range of living arrangements, and the longer term outcomes on physical, social, and emotional health on caregivers and infants in these guidelines. The major thing that we've been looking at is infant mortality. Of course, that is a hugely important outcome. I am not trying to minimize that at all. I think, though, we need to recognize that there are a lot more things than just mortality out there and longer term morbidities that will follow some of these families for a long time. So why does bed sharing happen? These authors, so Elaine Berry and James McKenna, are outspoken advocates of bed sharing. And have very interesting viewpoints that I would encourage those of you who are interested in learning more about some differing views on bed sharing to read some of their work. They've listed, though, a lot of the reasons why bed sharing happens. And I would scale it back just a little bit and say that largely to me, there are two camps of bed sharing, those that are reactive, meaning this was not a situation that was anticipated, and they've done this in the hope of improving some outcome, usually sleep duration and quality, versus proactive, families who always intended on bed sharing because they wanted to. And those are two very different viewpoints that will very much so color two different sets of outcomes and opinions around bed sharing. But breastfeeding, comforting the infant, improves sleep for both mother and child or parent and child, closer ability to monitor, improve bonding, environmental reasons, infant crime, cultural family traditions. There are some people who just do it because they disagree with the evidence that's out there, and then maternal instinct were all found to be common reasons why people still bed share despite these fairly staunch recommendations that have come out by the American Academy of Pediatrics. So to summarize updates on infant sleep position, there aren't a huge number of updates in terms of, it's been minor updates between 2016 and 22. So it is still placing them back to sleep in a firm, uncluttered surface, really in a room sharing situation, but not a bed sharing situation. It's important to remember that these are still major causes of death, particularly strangulation, SIDS, and sudden unexplained death in general. Sleep position is one of the multiple factors contributing to it, but it's not all. Hospitals are doing a bad job at modeling this, and we know that bed sharing is still occurring frequently. We need to learn a lot more about the various impacts of bed sharing beyond infant mortality. Again, not underestimating the importance and the absolute catastrophic things that occur when an infant does die unexpectedly. But there are a lot of potential unmeasured morbidities for both parent and child that are as of yet unmeasured and untapped. So let's talk about the impacts of infant sleep on health and development. I'm going to focus, this is a 10-day lecture series in and of itself. I'm going to talk specifically about infant insomnia and behavioral sleep interventions in the home setting, and then a little bit on sleep disordered breathing. So, I wanted to show this slide as a framework for all sleep disorders in infants. SDB in this slide stands for sleep disordered breathing. But it is a model that we can use, I think, for just about every sleep disorder out there, which is that if you have somebody who is along a healthy trajectory of development and ability over time, and you expose them to a sleep disorder, whether that be insomnia or sleep disordered breathing, then you introduce a treatment. And that may be treatment for their sleep disordered breathing, or in the cases that we're about to talk about, a behavioral sleep intervention. The question is do they recover and end up back where they were always going to end up? Do they take a delay, meaning that they will eventually get there, but it's going to take them longer to get there? Or do they take a permanent hit where they take it, where they will be at a permanent deficit and never reach that original potential? And those are the questions that we ask ourselves, in the sense of like, when we are considering a treatment for what we are considering to be a problem, what are these outcomes that we are hoping to achieve? And I'd like to think that all of us in this room who care for infants and work with infants are hoping for maximal neurodevelopmental potential for every infant out there. And I think there's a basic fundamental belief that infants reach that neurodevelopmental potential by getting at least a foundational good night's sleep on a routine basis. And so moving ahead with that, I cannot talk about this without talking about family function. And when I mean family function, it is household function, however you want to define family. I think it's a fairly loose definition, but I consider this the foundation of health. So what we know, and I use parent here because it was shorter to type out than caregiver, but really every parent loves their child, but likes them less when they're not sleeping. And this is just a fundamental truth. You are not happy if your child is not sleeping the way you want them to sleep. So short and long-term sequelae on that parent-child diet and larger family function ensues with that disconnect. So you have an intervention that is oftentimes attempted due to poor sleep, oftentimes due to cases of the lack of education that is there for both caregivers and providers, is a developmentally or biologically inappropriate intervention or unrealistic expectations. There is then negative escalation around the situation, and that just worsens the sleep problem. So remember that a baby who is exposed to that negative escalation, I talked about some of those neurotransmitters that occur in stress that actually prevent turning off that awake switch. Those things keep a baby awake. That's going to make the whole situation worse. These are really important, like, contextual frameworks that we have to consider every single baby in when we talk about sleep and problematic sleep. And what we know is that the impact of perceived poor sleep early in life can persist. So this was a study of almost 1,500 children in the Netherlands, and they were examined at their first 6 months of life and then followed up at age 2. And what the investigators found is that if the parents were unhappy or discontent with infant sleep in the first 6 months, that was related to a higher odds ratio, both by parental perception and then by questionnaire, of poor sleep between the ages of 12 and 24 months. And you can see those odds ratios there. And how does that translate into an individual person? I don't know. But we can certainly say, and this makes logical sense, that if you have early habits that occur early in life, those things probably do have some higher risk of sticking around until the kid is older. That's parental report. So what do we know that makes parents unhappy with infant sleep? The biggest thing is just difficulty with initiating or maintaining sleep. And the second is poor quality sleep. In terms of that difficulty with initiating or maintaining sleep, that those things result in, and these are like specific things that families get upset about, which is it takes them a long time to fall asleep. They have multiple awakenings overnight. They need parental intervention for any of this to be ameliorated. They have shortened overall sleep. A large cluster of these disorders is called behavioral insomnia of childhood. There are sort of 3 flavors, so to speak, of this. This terminology is a little bit, the newer updated terminology is just called chronic insomnia, but I really prefer, and I think that behavioral insomnia of childhood is much more descriptive. So I've chosen to continue using those words. There is sleep onset association, which is that there is a habitual condition present at sleep that the infant needs to have around in order to fall asleep. This is a funny video. I'm hoping this works. So you can see, oops. There we go. So you can see that in this situation, this kid has the vigilance that is helping to keep her awake just enough that as soon as that water turns off, she has to turn it back on. I mean, who does that? Like, right? Like, this is not something that biologically was genetically programmed into her, that she needed to sleep in the sink, the faucet running. This is something she's learned. And I would venture to say has really good vigilance and the good circuitry to say, this is how I sleep, this is how I am going to sleep, and I'm going to make this happen no matter what. Limit setting is the other flavor of behavioral insomnia of childhood, and that's characterized by parents' bedtime, by the kids having bedtime refusal, and oftentimes characterized by permissive parenting. This tends to be with older children and classically called curtain calls. So this is something where, you know, the toddler comes out of the room, the preschooler, I'm thirsty, I need a glass of water. No, not that glass, the red glass. No, not that red cup, the other red cup. No, I need it with a straw. And just constantly, you know, that parents essentially continuing to permit that to happen, as opposed to just saying, nope, it is time for sleep. And so essentially it is developmentally appropriate for that kid to try to test those limits. And some kids are better at persisting with that. Some parents are better at allowing it to happen or shutting it down, depending on the situation. So, and then more often than not, there is elements of both in terms of that combined type. So when does sleep not happen? So in that example of the baby in the sink, there may have been enough sleep pressure or not enough sleep pressure. Maybe it was a weird time of day, but essentially this kid had not the right associations to initiate and maintain sleep. And she had to maintain a certain level of alertness and vigilance in order to make sure that sleep association was present. That is going to disrupt sleep and impact total duration and disrupt quality. And those are all learned habits. And so the question is what happens to that kid long term? So this really brings up treatment in terms of what are our treatment options for it. We'll talk in a moment about whether or not we should treat, but if you did want to treat, what are the things out there? So again, this is an entire dissertation in and of itself, but treatment things that have been studied, looked at, you know, recommended by a variety of organizations and whatnot. Basic sleep hygiene, so scheduling, positive bedtime routine, putting the baby down while still awake and drowsy, but not completely asleep, and then parental education prenatally, so sort of anticipatory guidance. There are two forms of extinction. One is unmodified and one is modified. The extinction one is the classic cry it out. So you put the kid to bed at a designated bedtime and then you systematically ignore them. It's not a nice way of putting it, but it is the simple truth until a set time the next morning. This is the easiest set of directions in the sense that the answer is always no. No, you don't go in there. No, you don't reassure them. No, you don't change the diaper. No, you don't do anything. Modified extinction is a gentler version of that, where you put the child to bed at a designated bedtime, but then you systematically check in on the child. There are 100 million varieties and variations of how to do modified extinction, but the sort of driving force here is that the child will eventually learn to self-soothe as you sort of space out that checking in process. There is something called bedtime fading, which if it takes a kid a long time to fall asleep, that you move their bedtime back. Essentially, you move their bedtime to and their routine closer to the time of usual sleep onset. This is a very double-edged sword in young infants, where if they get that overtired state, it's actually harder for them to fall asleep. But this can be helpful in slightly older infants. There's also the fading of adult presence, which is moving away from the bed, or known as the camping out technique, where every night parent moves away farther out from the child. And so there's the physical slow removal of parent from the situation. You want to remember that any of these things, you want to do it in the environment that is desired to be the long-term placement. So you do not want to undergo extinction or bedtime fading or camping out from the parent. You don't want to do it in the living room if you don't want the kid sleeping in the living room long-term. You want to do it where you want this child to be long-term. You want to establish success in that environment for the child. The second thing to be aware of is that things called extinction bursts with any treatment implementation occur. So where it seems to get better quickly, but then, nights 3 or 4, 2 or 3, sometimes there's a worsening. There is a regression of some of that crying that parents can experience. And if parents aren't expecting that, that's oftentimes when they sort of give up or call it a failure. So the bigger question is should we treat? There's been a lot of parental pushback over the years in various forms and formats as against extinction, or what has been colloquially known as sleep training. There's been fear that it causes undue stress, that it is anti-attachment parenting, particularly for those who want a family bed versus a reactive co-sleeping situation. And a fundamental belief by a lot of them that there must be something wrong with their child's sleep or health that is the cause of these arousals, and that if the child is crying, that they're signaling for a reason. What do you tell these parents? I think, the answer really used to be stuff like, no, you still have to tell them to sleep train their kid. And I think we're moving away, or at least I'm moving away from that. Really, this is something that we've long known that parents should only undertake if they really want to. There may be education around the reasons to do it or not to do it and what's involved. But I think there is emerging evidence and reassuring evidence that even if parents don't do active behavioral sleep interventions, that things tend to get better with time, and the overwhelming majority of children do just fine. I think that's a very important message. And sometimes, especially with families and exposure to social media these days, get really hung up in trying to do things a certain way and having a certain expectation quickly that just isn't going to happen. I reaffirm with families that, yeah, it's going to be stressful at the time of extinction. And if it were easy, we wouldn't be here. We wouldn't be here if they do indeed choose to go through extinction. There is not great amount of research right now that supports that extinction causes long-term psychological harm, but I think this is very poorly studied, and certainly in the moment, it's nearly impossible to get data. There is some evidence that shows, and this makes logical sense, I think infants who are able to self-soothe and put themselves back to sleep as a developed and acquired self-skill after awakening can be more secure, less irritable, cry less, with improvements in daytime behaviors that sustain into the school ages. Things like that can happen. And it may make parents' life easier once sleep training, if undertaken, complete. About a decade ago, a string of papers came out suggesting that the presence of infant sleep difficulties early in life were associated with ongoing sleep difficulties later in childhood. And the data at the time were compelling, and they're still compelling. And it made sense in that it seemed logical that habits which were created early in life ended up persisting. And so I'm going to review some of these older studies, which still hold true. They're still valid. I just think we have more information now that may temper some of how we interpret some of this earlier stuff. This study looked at parental beliefs and objective actigraphy in child sleep, and really with a variety of measures, which I won't go into detail, but basically they looked at the kids at a year of age and then again at 4 years of age. And moms who had more limit-setting difficulties ended up with children who were poor sleepers. Parents who had more ease with infant self-soothing in terms of their ability to handle the baby self-soothing instead of needing to intervene had 4-year-olds that were better sleepers with less need for parental intervention. Those who had increased involvement at bedtime as a 1-year-old had persistent increased involvement with bedtime at 4 years of age. In this scenario, the parental involvement was viewed as a negative thing and not necessarily a positive thing. That may be right or wrong, I don't know. Nighttime feeding, if it was common at a year of age, used as a nighttime soothing, those kids tended to be poorer sleepers at 4 years of age. This was a small data set, but it had fairly good metrics, but it was a very highly experiential design. This was another study that came out about the same time by a group here in the US that looked at parental reported sleep issues at 6 months of age, and then again at time points of 12, 24, and 36 months of age. And what we can see is that the presence of parental reported sleep problems at 6 months was highly correlated, or had a high odds ratio, I should say, of persistent issues then at 12, 24, and 36 months of age, but particularly 1 year of age. And this was 359 parent-child dyads. Another study that came out did confirm what many of us suspected, though, which was that infants sort of like, we all knew, I think clinically, that there were infants who, quote unquote, figured it out earlier and those who needed a little bit more time. This study looked at 10 sites in 1991, so this is quite older at this point in time. But a good number of children. They did home visits, and they asked families, mothers in specific, at 6, 15, 24, and 36 months, these same questions over and over again in terms of nighttime awakenings, how many nights these occurred over the last several weeks, and how much of a problem it was, with a Likert scale ranging from not much at the low end and 3 at the higher end. And what this study interestingly found is that the babies could be basically categorized into 2 clusters, with 2/3 of them being early adopters of persistent sleep, in the sense that they, by 6 months of age, if these kids were quote unquote good sleepers, where they had very few nights where they required attention or had very few nighttime awakenings, that this tended to persist over time until they were, at the last follow point at 3 years of age. Interestingly, this study found that 1/3 of the kids were what they call transitional sleepers, where at 6 months of age, they still had nearly nightly, so 7 nights a week, of awakenings, the need for parental intervention, things like that, that without necessarily prescribed sleep intervention, just by natural history, that attenuated with time. And it petered out such that by 2 years of age, these kids tended to be about the same as those who had established sleep early in life. But this is helpful counseling, I feel like, that if you have a kid who is still challenging from a parental perspective and a sleep perspective at 6 months of age, that there is some light at the end of the tunnel, but this can seem like forever in the distance when you are in the thick of it. And if you tell a mom of a 6-month-old that, oh, it'll get better by the time they're 2, that could be the thing that pushes them over the edge. It's a long time, but it does happen. Does behavioral sleep interventions, or BSI, do they cause long-term harm? This study came out in 2012. That was a follow-up study, and it was really one of the first bigger scale studies that came out and looked at the long-term outcomes in 2 groups. One that was randomized to behavioral intervention of sleep, and a control group that just got standard education. And at 5 years post-intervention, so these kids were at about 6 years of age, about, like kindergarten age. The reassuring news is that there were very few statistical differences in the kids' behavior, in the kids' sleep, both habits and beliefs. Psychosocial functioning was similar, stress levels, parent-child relationship closeness, and parental depression and anxiety were similar between both groups. So if you are going to do a behavioral sleep intervention, is there one that is better or not? This was a randomized controlled trial between 3 interventions. So the first one was randomized to graduated extinction. Second one was bedtime fading. And the third group was just a control group that got standard education. And the results were that both intervention arms had improvements in how long it took them initially to fall asleep. They had decreased awakenings overnight with less overall wake overnight. The controls also had improvement in that wake overnight, and the number of awakenings suggested that just time alone was helpful. graduated extinction in this randomized trial had the most improvement in sleep duration. So if you look at total sleep time, it's this dark line here. Same study looking at infant cortisol and maternal stress levels. So these decreased in all of the arms, not stably and not always in a predictable pattern, but overall there was a decrease in all of them with time, and statistically not one was better than the other. What about behavior later on? So then if this, if that was initially at 6 months, at 12 months, there were no differences in the infants in terms of internalizing behavior, externalizing behavior, or attachment disorders. So all reassuring that, essentially graduated extinction, bedtime fading, and educational controls largely did the same in otherwise healthy kids. Dr. Honecker and al. Looked at sort of parental report. This was recruited out of a Facebook group for parental support around infant sleep. Regardless of BSI method, crying was reported to be worst on night 1 in all approaches, and that included unmodified and modified extinction, and then parental fading with and without support in the room. Night 1 was horrible for everybody, but it dramatically reduced across the first week for everybody. Parent stress dropped over that first week, but the first night was obviously the hardest, again, across all 4 conditions. Satisfaction rates and success on the first attempt were best with unmodified extinction and generally less high with parental fading with support. But notably, everybody did improve, or most people, I should say, not everybody, but most people reported improvement. The end goal was achieved, I think, faster in this study with extinction techniques compared to parental fading, but it doesn't mean that parental fading didn't get there. Also, regardless of which sleep intervention was chosen, nearly all kids ended up with a stable nightly routine, markedly shorter amount of time before they fell asleep, with the elimination of difficulty falling asleep and a decrease in night wakings and feedings. Those who chose parental presence techniques, so that these were parents who were in the room who were either moving out or decreasing or moving back bedtime, I should say, had a little less reported success with kids successfully sleeping in their own room. But part of that is just by design and reflecting their methodology. They still had success. So following up on that study, this group then took it one step further, and again, parental report, but this time with the added metric of infant videography. And families who chose, and this parental survey also had parents who chose to do no intervention. This was a large study where 2/3 of the families chose some sort of sleep intervention and 1/3 didn't. There were over 2,000 families involved. It's one of the biggest of its kind. At the time, infants were about 9 months of age when parents did this, but what they reported was that implementation of that behavioral sleep intervention, if they chose to do so, started around 5 months of age. So many people were not waiting until sort of the standard recommendation of around 6 months. Extinction was shown to be more difficult for families to implement, but if they did implement it, was more effective in that it was shorter and quicker to show improvements. And that largely confirms what prior studies had shown. Specifically to sleep duration, though, we know sleep duration and night wakings are huge drivers of parent satisfaction and perception of sleep quality. We know that health-wise, it's sleep duration and disruption that are big drivers of physical health. So when comparing these 4 groups in this study, sleep duration was longest in those who had gone through extinction versus parental presence, but all of them were within a reasonable range. And number of nighttime awakenings, similar pattern. Extinction was the fewest, with those who had parental presence a little bit higher. And again, I think it's important to remember that for one parent, waking up 2 or 3 times a night may seem like a great outcome, and to another parent, that may be a catastrophic outcome. The number of parental interventions, though, decreased to nearly 0 in all age groups beyond a year of age. So, are there things that we can do besides a formal sleep intervention that maybe would help with increasing total sleep duration, since we know insufficient sleep is so not good for overall health outcomes? they all tend to land in, the same place later in life, but are there simpler things to do to maybe get us there a little bit sooner? And this study was one that looked at standardized data across the National Survey of Children's Health in 2018 and 19. And the data I'm presenting are really across all of childhood, but it was, close to 14,000 children from ages 0 to 5 or 4 months to 5 years. Infants were about 11% of that population. And so I'm going to present the whole big cohort, though. They used a definition of insufficient sleep for this age group, as infants were sleeping less than 12 to 16 hours for 24 hours. And what they found is that the things that were highlighted were not necessarily like super high-tech ones. Structure was a common theme. So those who had regular bedtime routine that involved reading, singing, and storytelling oftentimes had more a higher total sleep duration than those who had, so if you look here, few number of days per week where they were reading to the children, increased odds ratio of having insufficient sleep. Parental education at the poverty level versus at well above the poverty level, being Black. Singing and telling stories at bedtime. If you didn't do this often, higher odds ratio. Family structure, weeknight bedtime regularity in terms of stability of that pattern. All of these things really point towards a couple of themes, one of which is really routine. And these are not necessarily things that belong to a specific behavioral sleep intervention, but they are, pretty basic education around routine. But one thing that you'll notice is that these things are way easier to do if you have a traditional job, that you are home for that evening routine, or you have, regularity of availability for that evening routine. It's also easier if you have a dual income household. And most assuredly, the increase in odds ratio on being Black have to do with these multiple other factors, including things like adverse childhood events, which mirrored statistical significance here, maternal mental health, many of which are due to centuries of inequities and oppression of the Black population in this country, and have nothing to do with the fact that they are like this old theory of them being genetically different. This is really just results of decades, centuries of systemic oppression. How do we pick what works for families? So if you have a family that is considering behavioral sleep intervention and is looking for recommendations of what they should do, I usually take into consideration a couple of things, but the biggest thing I take into consideration, the biggest two things are parental tolerance of crying and the need for detailed scheduling or flexibility. This is an algorithm that does have books here. I'm not per se endorsing these books, but these are just examples of how this algorithm works, which looks at age of the infant, the amount of crying that a parent is willing to tolerate, the need for a very fixed schedule versus a lot of flexibility, and then putting them towards a path of certain books that may be helpful. I think where a lot of parents struggle is that they ask what book should they read, or they go to resources that are online, they look up what's available, 5 stars on Amazon, that kind of thing. And it may just not be the greatest fit for their temperament, for their lifestyle, for what they want in terms of how much presence they want or how much crying they can tolerate. And so they read all the books and they try, but they're unable to execute what the book is recommending to its fullest. And so then they fail, and then sleep becomes a thing. So that's just an algorithm there that you guys can peruse later. And then atypical response, just a final word here, atypical response or persistence of these sleep issues, despite what seems like reasonable parental effort. I have to say, I think we're learning more and more. I do believe that this is where developmental differences and children who ultimately may or may not be diagnosed with more formal neurodevelopmental differences later on do emerge. Sleep is one of those neurologic things that and skills that they have to learn early in life. And when that is different and diverges at an early age, sometimes that really is the first manifestation of a diagnosis to come. So just to keep that in mind. And our last few minutes here, I'm going to talk about sleep disordered breathing. So a lot of people used to say that snoring babies were cute. And I would argue, especially from a pulmonary standpoint, that snoring babies may be cute, but it's not good for them. And so this series of studies looked at infants who snored in their first 6 months of life. They looked at them at 6 months and then at 12 months. And the snoring babies in the first 6 months of life were associated with having lower cognitive development scores at both 6 months and 12 months. And you can see this difference here. Importantly, these were the control kids who didn't snore. These were the snorers. There's a wide variation. These are largely within the realm of still pretty typical and a normal spectrum. But if you said to any parent, would you rather have your kid up here or down here? I know very few parents who would pick the ones down here. And so how that translates into longer term impact and function, I think we have yet to fully study. There are some interesting cohorts that have come out of Europe primarily. This was a large study looking at 11,000 children in the UK, where they asked them about snoring, mouth breathing, and apneas at 6 and 18 months of life across until they were in school age, until 7 years of age. And what they figured out is that those kids who had some degree of snoring at any point and with any persistency or irregularity, so either just any snoring in early childhood, was associated with more problems at 4 and 7 years of age with hyperactivity, conduct disorders, emotional regulation issues, peer relationship difficulties at 8 years with special education needs. Obviously, this is not a study of causation. This is just association. There were not necessarily genetic conditions or other neurodevelopmental conditions that were ruled out because, didn't know that they were there when they were infants, but it is something that definitely highlights that we should be paying attention and asking if the babies are snoring. Every baby should be able to lay on their backs, sleep with their mouth closed, and not make noise. So, updates on impacts of sleep and developmental health. Some of the summary points is that behavioral insomnia remains a common problem. I think social media has frankly made it worse because of worsening parental perceptions and expectations. We know that behavioral sleep interventions can improve sleep quality and quantity. It can decrease parental stress, but we also know that time will just take care of a lot. And this is a slightly different thought process than what earlier studies have shown. There are fewer differences between the various techniques than previously believed. There are reassuring but very limited data that at least in the few studies that have been done, there aren't a huge number of long-term adverse impacts that were identified. And there may be benefit. We tended to focus on the negative, but maybe the positives outweigh it. We're not sure yet. But that the methodology chosen, if desired to be chosen at all, should be driven by infant temperament, parent tolerance of crying, or need for scheduling and flexibility. And that snoring in infancy isn't just cute. It could be associated with a predictor of, who knows, a causal relationship of later behavioral, cognitive issues, and possible sustained obstructive sleep apnea. So overall, we've touched on these things today, but there is so much more to learn and understand. It's just the tip of the iceberg, but we know, I think incontrovertibly, we know that those infant months are so very important to family function in the parent-child diet. We have to be incorporating how sleep impacts infant mental health and development and parent mental health and behavior, stress, things like that, that we know influence that child's outcome. So with that, I'm going to stop sharing. I'm a little afraid, but I'm going to open the chat.
And I'll help you navigate that. I can read some questions. Thank you so much. That was really interesting. And I love the update on the comparison of these different methods. That was just really helpful. And I also really appreciated the algorithm to consider parents' tolerance and schedule. Yeah. Like these are the two factors that something's not going to work if you can't, you have to have that conversation. We have to find something that fits for the family.
You really do. I think a lot of prior thought and practice was centered around if the parent just needed to learn how to suck it up and listen to their kid cry. And that's just not the truth, right? Like, just because a parent doesn't have a great tolerance for listening to their baby cry doesn't mean that they don't want that baby to sleep independently.
Right.
And that is an incongruence that a lot of us were not necessarily embracing in prior iterations of these sorts of studies. So how shall we do this, Monica? I don't know if you
Well,
were able to.
I can start reading off some questions here.
Yeah,
So, you did touch on the neurodivergence,
yeah.
neurodevelopment differences. Is there anything to add to that? Because that was a question that came up a couple times.
I think there's going to be much to learn. I think, we're going to have to end up going backwards. So cross-sectionally right now, we know children with ADHD and autism, which are probably the two biggest neurodivergent populations studied, have significant sleep differences. And a lot of those come down to the insomnias. They have difficulty with initiating and maintaining sleep. We know it is a huge negative impact on their quality of lives. And we know that a large portion of ADHD treatment and treatment for autism centers around sleep treatment, which often involves empiric trials of every single medication on the market, or not even on the market, for those sleep difficulties. I think if you ask those parents, a lot of them will endorse that from a young age, they had different sleepers as infants, but that they were told or coached or embarrassed, but just said, like the kid will figure it out, or and then the kid didn't figure it out, or that this is a parenting fail in some regard.
Right.
And I think what we have yet to learn is how much that inflection point influenced what that child is like now. That child grew up in an environment of just a definition that they were bad sleepers, and it didn't change until they were older and, push came to shove. I will say that inflection point tends to be in school, when suddenly they are expected to sit still and learn, and that is clearly not happening in an optimal way.
Thank you. One person asked, are there instances where wedges are still acceptable? I see clinicians describing the case in reflux. Is there a risk-benefit analysis for medically complex babies?
Excellent question, and it is an incredibly hot topic here at Children's right now. I will just say right now at Children's, if you want to send a baby home on a wedge, there are like 800 people who have to say yes or no. It's a little bit absurd. There is a difference, I think, between the use of wedge for therapeutic positioning and feeding while this child is awake. And I don't know that these things impact that decision to send a kid home with the wedge. I think it's really when it comes to sleep positioning, you look at the odds ratios essentially of, is that kid at higher risk for dying of SIDS, which we know these wedges and subideal, positions promote, or are they at higher risk of dying of something like obstructive sleep apnea, which is treated with wedge positions or even prone positions in certain populations. I would really suggest that this is a population that we need to aggressively study and look at their outcomes long term. Right now, a lot of those kids weren't sleep studies to sort of show that their obstructive sleep apnea is clearly treated with wedge positioning. But yeah, so I do strongly believe there are populations that need the wedge. For some of them, it saves them from a tracheostomy, but it is probably not as point blank as it was in the last 5 to 10 years, where it sort of became a standard issue recommendation.
Right. There's a couple questions about holding infants to get them to fall asleep. I guess this is really going to the habituation question. Yep. And also in childcare settings, so to hold, not to hold. What is your thought about that? And I know too, developmentally, it's gonna vary.
Yeah, and I think that really depends. How you answer that question depends on what the goal is. In the childcare setting, if you have one baby that is setting off an entire room of babies, probably for the sanity of everybody in that room, please hold that baby so that baby will fall asleep. I mean, that's a situation where holding that baby makes total sense. I think, though, if there is a goal of really trying to capture this window where the baby is figuring out sleep association cues and figuring out their circadian rhythm, if you want to sort of, quote unquote, beat them at their own game, yeah, put them to sleep when they're still awake, so that when they figure it out, they're in their crib instead of in your arms. And they're just not going to hold up a flag and say, today's the day. But there are just so many nuances that go into answering that question. And I also think even in the home setting, so outside of the daycare setting, if that parent needs to sleep and that's the only way they're going to be safe to drive the next day, like there's been no studies looking at that, and I think that's a huge safety element that we have to address.
Right. Another person asked about the angle of the bed. If we don't use wedges, can you change the angle of the bed?
Yeah, so the recommendation is less than 10 degrees. You have to be careful with how you do that with cribs. And so, it's in theory, you're supposed to elevate the entire mattress. It's hard to do with a lot of traditional cribs. In hospital cribs, it's an easier thing to do because there is a flex point in it. But you're supposed to put something underneath the mattress in order to elevate the entire head. But then you really need to make sure that the kid is securely not just sliding down and getting wedged in the bottom of the crib.
Right. I never see any studies on how humans want to sleep with their babies versus how other mammals sleep with their newborns. Obviously differences, but I do find that we tend to intellectualize a lot rather than tapping to instincts and understanding. I guess it's not really a question, sorry.
Just a
But
comment
that's
though.
an interesting observation, right?
It's a very interesting observation, and is one of the most common reasons why mothers do bed share is that it's instinct. You want to be there for your baby. I think, it's hard because we are in a world where unfortunately many of our instincts are not allowed to be followed through upon completely, right? Like if your instinct is to take a nap at 2 p.m., a lot of us have jobs where that is like going to get you in trouble. And so you can't do it in that sense. And so I think we unfortunately live in different constraints where instincts don't always get to rule. But I think it's a fascinating topic. And many would advocate that maternal instinct is the safest one out there.
Right. It actually goes to another question about the AAP, this idea of co-sleeping and cross-cultural differences. Why, since people do bed share, why doesn't the AAP make recommendations about how to make that safe and reduce parent stress around sleep, and acknowledging those cultural differences and look at other countries that actually don't have guidelines? But
I don't know who asked that question, but we need to go have a cup of coffee or a glass of wine together because I have the same exact beef. There are lots of countries where co-sleeping is standard and in fact celebrated. Japan, Thailand, they have the lowest rates of SIDS. They all co-sleep. A lot of that we think has to do maybe with rates of maternal smoking and family support systems. Their moms are, in theory, less exhausted because they have more of a community around them. But it is a fascinating question, and I don't know why the AAP doesn't go there. I understand that their primary, I'm looking at somebody's cat here. I understand that their primary goal has been infant mortality in that sense, but man, there's a lot we have to learn from the rest of the globe. There really is.
Yeah. And another person asked, really, do other countries have sleep consultants, or is it just a Western problem?
It's a Western problem, really.
Yeah.
I mean, and so it's an industrialized thing, and it's very much so a thing because we don't have protected maternity leave. I mean, just to, I don't want to get that political, but you may not want to open that with me, but because we have our moms go back to work at a time that infants are not biologically capable of sleeping through our definition of night on their own. And other countries really have prioritized giving them that protection. So it's a very different scenario when our moms go back to work. And so we have different moms.
Right. Another person asked, are sleeping patterns genetic?
They can be. So temperaments are oftentimes genetic, and those thresholds of where your sleep switch turns on and your wake switch turns off, those thresholds likely have major genetic polymorphisms. Circadian rhythms we know are hugely genetic. Oh, Siri thinks I'm talking to her. Is that night owls beget night owls. So if your parents are night owls, babies will be night owls. And those babies oftentimes get in trouble because they're not going to sleep until 10 or 11 p.m. in preschool. And people think that's bad parenting, and really it's just genetics.
Right. What interventions are appropriate for snoring?
There's a lot that we've learned about snoring in infants. And so There are certainly some surgical things out there. I think there are some dental and orthodontic things that are in the environment, but the biggest thing is whether or not this kid has structural craniofacial differences that will follow them into later life that need to be addressed at early ages.
Okay.
But that is something where positioning sometimes is the treatment. If you flip them on their belly, does it go away? Maybe
Right.
flipping those kids on their bellies. I know that's complete sacrilege to say.
Right. Can you repeat what you shared about monitoring? Did you say devices like Owlet can be used or are not recommended?
They are not recommended. So what the guideline said is that you can use them if you want, but they essentially provide a false sense of security. Their use is really supposed to be for wellness. So if you are somebody who's just like, I just want to know what my baby's oxygen saturations are, go ahead, use the Owlet. If you are using those oxygen saturations, though, as a surrogate to say, well, if they're high, my baby's not going to die tonight, that's wrong and that's misleading.
Okay.
Same goes for the SNU. I kind of saw somebody put that in. The SNU was originally marketed as an anti-SIDS device. It is honestly no such thing. It puts babies in a certain position. It is preclusively expensive for most people. And honestly, SNU users fall into two groups. You love it or you don't. I mean, some people swear by it. Some people say that it did nothing at all and was the biggest waste of their $2,000. So it is not, though, something that has been proven to truly reduce the risk of SIDS.
Okay, so it's 11:30. I have to pop off to a meeting. Dr. Chen did say that she could hang on a few minutes. We
Yeah.
didn't get to all the questions, so I don't know, Carol or Jen and Maureen, if you guys can stay on with Dr. Chen. For those of you who have a few more questions, maybe re-enter them into the chat if someone can help with that. I apologize. I have a meeting I have to go to. Thank you, Dr. Chen. This was phenomenal. Really appreciate it. Obviously, a very, very important topic that lots of people appreciate. So thank you.
Yeah.
And I'm going to pop off, but you guys can stay on.
Yes. So I'm scrolling through this chat, and I'm going to pick on one thing that has now filtered through my eye a million times, which is melatonin. There were several questions about melatonin and its use in children, presumably for helping with sleep onset and maintenance. Melatonin in this country is a supplement, and so it does not go through the same level of testing that other pharmaceutical products do. It goes through the same level of testing, though, that multivitamins do. So if you feel safe giving your child a gummy vitamin, largely you should feel safe about giving them a melatonin supplement. What we don't know is how much melatonin is actually in that melatonin supplement. So that gummy that says it's 1.5 milligrams, it could be 200 micrograms, it could be 3 milligrams, or some range like that. It's quite huge. A lot of the data that we have on melatonin is done by other countries where melatonin is a prescription. It's pharmaceutical grade. That's hard to get in this country. Generally, if given at the right time, timing is very important with melatonin. It does help with decreasing the amount of time it takes to fall asleep, but it generally does not help with sleep maintenance. Most studies in children have been done on kids who have ADHD or ASD, and it is helpful in those kids for the most part, but it is it's an adjunct treatment to things like behavioral interventions. Tends not to be a cure-all. The other good news with melatonin is at reasonable doses, it doesn't look like there are huge long-term effects, or at least 2 to 5 years out on kids with autism. It doesn't seem to be affecting their puberty or their growth, which were some initial concerns. I honestly do not give melatonin in infants, or very rarely do. A lot of times infants come to me with families who have already given it. They tend to be children who later are diagnosed with neurodivergent conditions. I saw a question like flit up there about fetal alcohol and other things like that. Those are a lot of those neurodivergent conditions, whether they were acquired from teratogenic exposures or they were genetic for whatever reasons. You got to learn those kids' circuits. You have to learn what sort of makes them work and not. And honestly, at this point in time, standard of care is just going through just trial and error of medications. There is not a great algorithm of how to first approach it. I will say, I think behavioral modification is central to all of their modifications, but the reality is there's not enough parental education out there. There's not enough support for parents. And sometimes you have to rescue people from the cliff. And so we will medicate kids sometimes way earlier than I would like to in order to really keep people safe at home. So